Hey guys, welcome to the first episode of Warrior1Spine webinar series for 2022. We were just talking with Pascal a little bit, and just wanted to just publicly thank Pascal for doing this. It's awesome. It's an awesome way to hone our craft and make sure we're moving into excellence in terms of spinal reconstruction. Before we get started, actually today, today we're going to be looking at the research and the case studies that have been published on the impact of cervical correction on the visceral disorders and systemic disease. Today we'll start off in just a little bit, but the next one that's coming down, I believe it's in I don't know the date, but it's coming up. So the next one's going to be pediatric cervical curve correction, which is going to be awesome. And so during that webinar, we're going to be going to review of pediatric cervical correction research, along with pediatric X-ray analysis and indications for pediatric tractioning. And if you look at these two, actually, I'm just going to change my screen here. If you guys look at these two X-rays, I was just talking to Pascal about them. These are X-rays that I took in 1998. Actually, the first one is 1998. And we were just talking with Pascal, just like how this is impacting, current reconstruction docs and correction docs. But I was just kind of talking to him about, I believe it's going to actually, people are going to go back to these talks for hopefully decades, because back in the 90s, we didn't have too much research. Actually, in 1998, when this first X-ray was taken, just to let you know too, this is at that time, this was my youngest. This is the X-ray of my youngest patient I've ever took. I mean, so this guy's name is DeWitt, and he's 4 years old when I took this X-ray. And just to give you an idea, so spinal reconstruction was just because Don and Deed were, CBP was really starting to launch, and then the tractioning, I don't know where Denerol was, but we had never heard of it at that point. I'm not sure exactly when it came out. Maybe Pascal can answer that question in a little bit. But we were doing basically a rolled up towel off the side of a bed with a whole kind of head harness, and you added weights to the back of you clipped on weights and you just went right over the bed. And that's how we would do the spinal to get the curves back. But and I alluded to this one of the other episodes is, so Ruck, like Human Atlas, the Atlas of Human Subluxation, Ruck's book came out, I believe it was actually spring of 97. So this was 98. And Ruck's book really kind of blew our minds in terms of being able to see the spinal cord and the damage and, disc bulges and just the anatomy from the dissections, and really it just really put it together for me. So the research I had at this point, basically with pediatric reversals, was basically, if a reversal is bad in a 50-year-old and in a 70-year-old and a 30-year-old, it must be bad in a 4-year-old. That's and I wanted to see the spine, right? I could palpate, he was stiff, but I wanted to see the spine. Turns out to be a reversal. With DeWitt, to give you an example, just to give you some background, DeWitt came in, and his dad brought him in. His dad was a patient for a few weeks and was getting amazing results. And DeWitt came in. He used to be, every 2 weeks he'd end up in CHI or emerge, and he'd actually have life-threatening asthma. So he'd go like super acute, massive, life-threatening episodes. So he'd go into emerge, and they'd pump him full of drugs and have him sleeping in the oxygen tent for about 24 hours, and then he would get through his episode. And here again, do I have a problem with a drug that's needed in the moment to save this little kid's life? I don't have a problem with it, but the body's adapting. There's more drugs. It's happening more and more. It's getting worse and worse. So like I said, is like, hey, this is bad. This is a reversal, maybe taking the pressure off the spinal cord here might actually help the asthma. Well, 12 months later, and the recommendations most likely was like in the 70s. So twice a week for 26, once a week for 26. This is DeWitt 12 months later, and doesn't even take a puffer at this point. Off all the puffers, the bronchodilators, off of everything. Completely completely healed up, which is awesome. And it's actually a funny story, and I don't know if I've ever shared this story. His dad, and this just adds to the legacy here. His dad actually, when we sat down and went over we went over his care plan, and he was a 91, and then we went over DeWitt's care plan, and he's going, okay. He actually, when I got down to the finances, he's the one that pulled out 4 Rolexes and just said, well, you can choose any one of these. And like, I just stepped away. I don't even know if they were real or not, but potentially they were. And I know, don't get it. I know the value is probably like quintupled, over the past 24 years. But anyways, he paid cash. Yeah. So pediatric cervical curve correction. It's amazing to me how much research there is now compared to what we had before. And what we had before is just like, yeah, reversals are bad for everybody. That's what we had before. Next topic is going to be, after that, a lumbar spine correction. A lot of you wanted to start looking at the research for the lumbar spine and the protocols. So we're going to go over the lumbar x-ray analysis, indications for lumbar deneral, how and when to progress to larger sizes, and the corrective exercises used in conjunction with the lumbar deneral. And, is interesting is the postural correction exercises, Dr. Pascal, is the most viewed webinar after what spine surgeons say about spinal reconstruction and cervical lordosis restoration. So anything to do with the postural exercises, I think you guys love it because you can implement it right away in your practice. So we're going to be going over that for the lumbar spine correction also. And then the last episode for this year is going to be the safety of pre and post radiographic analyses and spinal correction. So we're going to go over radiophobia versus radiation hormesis. We're going to be reviewing the current linear non-threshold model. And I say current as in current. We're going to be going to radiophobia and its false assumptions leading to fear-based X-ray avoidance. And we're going to go over the lit review of radiation hormesis, suggesting possible health benefits. And that's where the hormesis comes in, of low dose radiation. A lot of research coming out on this. Actually, it's one of the things that we went through with Dr. Scholten also. So yeah, so that sums up the year, or what's coming down the pipe. Here again, guys, just ask you to check out the YouTube channel, subscribe to the channel, like the videos. It just helps get the videos out. And the Warrior1 Instagram too. So go to Warrior1Spine Instagram. And what's really good about the Instagram, you'll still hear what's coming out and stuff, but also if you go to the bio, just underneath in the bio, if you go to the link tree, is that we're going to always have the last 4 episodes posted or linked into the link tree. So you can actually watch from your phone, which, you can do with YouTube too, but this is just a quick way to get there. You can, just listen to it while you're driving, but also it allows you to share. And it's just like 2 taps and you're sharing the video with, with another doc, or with a doc that's frustrated with their profession or with their practice, the clinic, or the way they're practicing. And students, like just I just wish we would have had this stuff like right off the bat. Even though we didn't, we did very well, but still, it's just there's so much research with the spinal reconstruction. So you make sure you share it, check out the social, it's easy to share. And that's it for me. So yeah, the impact of cervical curve correction on visceral disorders and systemic disease. Take it away, Pascal.
Well, thank you, Dr. Zed. Thank you, Dr. Yuri. I appreciate the opportunity to be here again for a new year of doing these webinars. I absolutely love doing this, and it's always fun for me to dive into new topics and try to help give docs as much clinical confidence as possible. And so it was Dr. Aaron, I guess, who suggested this topic, and maybe a few other docs who wanted to see the impacts of curve correction on visceral disorders. So I put it as visceral disorders and systemic disease, and we'll see why on the back end, okay? Let me just bring up my screen and let's go all the way to the top. And can everybody see my screen here? Are we good?
Yep.
Thumbs up. Beautiful. Okay. And I think, was this year 5 or 6 now that we've been doing this? I can't remember if it's been 5 or 6, but I want to say thank you again for having me on again. And thanks to the docs who've been loyal and watching these and trying to become better in practice and trying to implement some of the skills and the info that we give you to always be better and just strive for better results for your patients. So I love your dedication, and I think this is a really fun topic. It was for me. And I'm going to blast through slides because there's a lot to cover. I'm not going into detail about where the dental row was placed and what was done. Like, maybe a few slides will talk about that. I am trying to show you the knowledge, the breadth of information that's out there. I'm going to talk about why some studies are good and why other studies aren't good, and how this study could have been better and how this study is better than that study. So we're going to talk about sort of the hierarchy of evidence and how there's data for our profession, but I want to talk about how are we going to make this better in future years, right? And like Dr. Ed mentioned, he wishes he had this stuff back in the day, and now we're starting to trickle. But with every passing year, the more we get chiropractors on board, the more money gets put into nonprofit groups and into this type of research agendas and research associations. We're going to get better and better research to support specifically subluxation-based corrective chiropractic care, which is what we all hang our hats on, right? So this stuff is important. It's important for you to know these articles so you can talk about it with your patients, to protect yourself as a chiropractor, and to really improve your clinical confidence, okay? So let's dive in. First things first, I want you guys to see where I got every single article from. That's not to say I don't know if I got them all. There might be more out there, but we talk about curve correction. And the two entities that are producing curve correction research on a fairly large scale when it comes to improving conditions in chiropractic, visceral conditions, not only pain and headaches and that boring stuff. When we're starting to talk about the nervous system and viscera, it's CBP nonprofit. Okay, so very simple, cbpnonprofit.com. So any article that I am talking about today can be found on one of these two links. So note them down, remember them, because this is a great directory or reference for all of you to have. CBP, where the majority of them come from, and then ISHP nonprofit, the Institute for Spinal Health and Performance. This was recently started by Dr. Curtis Fedorchuk and Dr. Douglas Lightstone, again, just to have a separate body of evidence next to CBP. So it's not always just CBP, right? We're trying to grow the bodies of research or chiropractic professions, associations, I guess I should say, that are building this type of research, okay? So note those two down. This is where I got all of my articles for today. So we're going to start with some of the, we'll call them weaker articles, or the ones that aren't the best. And we're going to try and build towards the best articles, or the ones that have the highest impact, in my professional opinion, towards the end of the webinar, okay? So we're talking about the first condition. We're going to talk about GERD. Well, let's just face it. If you've been in practice for more than 2 weeks, you've probably helped a patient with GERD. It's almost guaranteed. I think we need a good large-scale study done on the impacts of chiropractic and GERD, but more specifically curve correction in GERD. So here's a case study. And a case study is good because it shows us the possibilities, but you have to remember it's only a subject of one, okay? And this is probably one of the weaker studies for the simple reason that this patient not only underwent chiropractic care, but they had a dietary plan that was introduced. So anybody that wants to sort of naysay the effects of chiropractic will say, well, how do you know it was the chiropractic care and not, the dietary program that helped to improve this person's gastroesophageal reflux disease? So this case is great. I'm glad it's published. But the knock on it is that two things were introduced at the same time, and you don't have a control to sort of separate and say, yeah, the effects, the improvements were because of the chiropractic care and not the GERD, okay? But this one is published. It was CBP protocols. Now, this is the Annals of Vertebral Subluxation Research. I'm glad it's published, but this is not a high-impact journal. Why is it not a high-impact journal? Because this is produced and owned by a chiropractor, right? So then, again, same thing, the naysayers, the people that want to attack the research are going to say, well, there's a bias there. This is published and produced by a chiropractor, Dr. Matthew McCoy, who's a wonderful human being who does amazing work and is trying to push our profession forward. But it's probably much easier to get a paper published in this journal than it would to be, published obviously in the Journal of Spine or the European Spine Journal or the Contemporary Chiropractor. So, there's a hierarchy to the quality of journal where these articles are produced, okay? Now, here's a little bit better study. We get into a better study. Why? Because now in this study, multiple things were improved in this patient, And this patient only did corrective chiropractic care. There were no other outside interventions. So here's a 76-year-old patient who came into, again, Dr. Curtis Fedorchuk's clinic, and this patient was having different symptoms that were diagnosed as muscular dystrophy. She was having weakness in the legs. She had high blood pressure. She was getting headaches and having vertigo. And so after 6 weeks of care, she was able to get off all of her blood pressure medication. And after 4 months, she had a complete resolution of the muscular dystrophy symptoms and a massive reduction, obviously, in her hypertension. So here's a great study because they were measuring this stuff and the patient wasn't doing anything else along the way. And although they used corrective care protocols, a knock on this study is they never redid x-rays on the back end. So now it's really hard to justify that it was curve correction that created these changes because we didn't re-x-ray, right? And so again, I'm presenting these to you so that you understand the nuances of these articles when you're sharing them with people so that, you know, you're not going in unarmed and saying, well, look at this article. You have to understand they didn't re-x-ray. And so we can't really say for sure that the curve correction made the change here, okay? So this is also where you learn when you're publishing these studies, you say, okay, next time, let's make sure we retake those x-rays so that we can state specifically that the change was because of curve correction. All right, so now here's a little bit better article because now we are same thing. You're getting into a condition that is much more common, dyslipidemia or just high cholesterol levels. The patient underwent corrective chiropractic care and they measured the curve correction pre-post. So post-care, they had a 3-degree improvement in cervical curve and they had a 17-millimeter reduction in anterior head translation. Wonderful. So they measured 2 things specifically on the x-rays and they showed, and the patient didn't do anything else, right? And what happened was they improved their triglycerides, the bad cholesterol, and they improved the LDL, and triglycerides both decreased while simultaneously the HDL increased. That is a really cool study. I would like to see further studies done on this. Again, something like a randomized clinical control trial on a large scale for something like dyslipidemia. It would be very cool. Okay, so it's a little bit better article because there's good measurements pre and post and no dietary interventions were changed. The patient did not take the statins that were prescribed by their MD in this case. So a pretty cool case. MS and lung function. This one is even better because now we're measuring multiple things on the same patient and the patient did not do, again, any outside interventions, only corrective chiropractic care. And we measured lung function and grip strength. Now, this is a patient that had MS, so this is a pretty advanced case. The patient had MS for 22 years. They were in a wheelchair coming in. Very important to know now, when we're talking about, we'll call it curve correction, right? We said curve correction, but it's not just like the cervical curve. I'm not just talking about putting a curve in. We could be looking at, you know, x-rays from the front too. In this case, the patient had a substantial shift in the head over to the side. This is abnormal from the front, right? There's a curve or a shift in the spine from the front when it should be perfectly straight. So curve correction could be reducing an abnormal curve when I look at the spine in the frontal plane. And this was the case on this patient. They had a 17-millimeter head shift over to the side, and all of the care protocols and the traction was all done to basically bring, you know, C2 back over top of T4 and have a nice straight spine from the front, okay? So really cool in that her lung function improved. She was able to have a higher peak flow and higher expiratory forced volume. So she was able to breathe out harder and she had a better lung volume flow. But what was most impressive in this case, in my opinion, is her grip strength. So this person's grip strength coming into the office was 2.8 pounds on her left hand and 3 pounds on her right hand. If any of you were measuring grip strength or have worked with grip strength, you would know that this is like almost gone. This person, like my 3-year-old son, can probably use one of those dynamometers and you squeeze it really hard and it measures your strength. I would bet you my 3-year-old has a higher grip strength than 2.8 pounds or 3 pounds. So this person's MS was very advanced. Okay. Now, what was really cool is after she did the chiropractic care protocols, the CBP care protocols, her grip strength in her left hand went from 2.8 pounds to 12 pounds. So for someone that has had MS for 22 years, a very progressive neurological condition, she had a 3-fold, like 300% improvement in her left hand strength, and she had 5-pound increase in her right hand strength. So almost doubling her grip strength in her right hand. Super cool study, okay? And it's also a bit more impactful because we have other studies that I'm going to show you in a few slides where we start looking at curve correction and lung function. There's a lot of curve correction and lung function. Okay, this one is a very exciting study, and I'm sure most people don't even know it exists. And this is another one, same thing. Great, it's a case study of one. We need more money and more support to get randomized clinical control trials on something like this, because this would be blockbuster for chiropractic. This is Dr. Curtis Fedorchuk, and here's the first article that I'm showing you that's not published in a chiropractic journal, okay? This is published here in the Journal of Molecular and Genetic Medicine. So I can promise you there aren't very many chiropractors that are reading this. So what makes this article great is that we're getting good information, we're getting good data into the hands of other healthcare providers, right? We want to show the rest of the world. We don't just need to preach it to chiropractors. Other healthcare professionals need to understand that as we start to improve the curve in the spine, we can have a massive impact on overall health, visceral function, and systemic disease. So here is a case study where the patient came in and did corrective chiropractic care. They had a reduction in anterior head translation. They had an improvement in the cervical curve by 9 degrees, and they measured the telomere length pre and post care. The improvement in telomere length was 8.23% at the end of the corrective chiropractic care protocols. That is amazing. So I'm sure most of you are familiar with telomere length. It is a biomarker for aging. We're born, our telomeres are their max length. And then as we age, the telomeres shorten more and more, and it's associated obviously with aging and oxidative stress. So if we can show on a large scale that as we improve the curves, we're not only increasing telomere length, but imagine if we can just stop or slow down the speed at which they reduce. You know, we can start to argue that chiropractic care has an almost anti-aging function. Very cool study. That one excites me very much so, okay? Another great study, again, Dr. Curtis Fedorchuk. I mean, the guy's a beast. He runs a full-time clinical practice. He has a young family at home, and he produces every single article I've shown you so far has produced by Dr. Curtis Fedorchuk. The guy is, I'll use the word obsessed with improving our profession, with getting us this data to support subluxation-based chiropractic and improvements in the nervous system and visceral function. This is in the Journal of Diabetes and Metabolism. This article was so impactful that he was actually asked to go and present to different rooms of endocrinologists and medical doctors. He's gone to different conferences around the US to talk to doctors about this work and how he helped to fix the thoracic spine in not only this individual, but there are 4 other individuals now where they've improved the thoracic curve, and the patient has had a substantial reduction in their hyperglycemia, right? Type 1 diabetic, and decreases in their HbA1c. This was the most blockbuster case. This is the first one that was published. It was a 26-year-old male who came into the clinic, and when they took the x-rays, they noticed that this patient had a reduction in the thoracic kyphosis, specifically T6 through T9. Interestingly enough, that's where the centers and the ganglia and the nerves go out to innervate the pancreas. So this patient underwent the corrective chiropractic care protocols, and after 3 months, you have to understand that most CBP protocols, it's always 3 times a week for 12 weeks, and then we re-x-ray. So at 36 visits, there was a 13-degree improvement in the thoracic kyphosis, okay? The patient's HbA1c, if you follow those numbers, and you know this, had decreased from 7.7% to 6.7%. So they dropped a full percentage point. Under 7 is technically not even a diabetic, especially if you're looking at a type 2 diabetes case. So they had a full point drop in 3 months in HbA1c. The patient did not change what they were doing. Like, he kept eating crappy food and so on and so forth. What's even more impressive is at 70-week follow-up, right? So like a year and some later, when Dr. Curtis Fedorchuk had followed up with him, this patient's HbA1c had then further reduced to 6.1%. Under 6 is no longer even considered a diabetic. So an amazing change in hemoglobin A1c. What was really cool is what they were doing is they were taking screenshots and they were measuring, because this patient has a continuous glucose monitor. So it's basically implanted into the arm or implanted into the stomach, and it's measuring blood glucose in real time. And I was talking to Dr. Curtis about this, and he was saying you had to watch the patient in traction, because once they would start pulling on the thoracic spine and removing the tension from those abnormal segments, the average drop in blood sugars was over 80 milligrams per deciliter. That's obviously in the US conversion system, but that is a huge, huge drop. So if a patient is having like a hyperglycemia event, you could put them in traction and boom, their sugar starts to drop. The average drop was 80 plus milligrams per deciliter. And he said that reduction in sugar would last on average 3 hours after every single session. Pretty cool study. So again, I want to see a large scale randomized clinical control trial so we can start telling patients, hey, you got diabetes, come into my office. We're going to help you. We're going to fix this, right? Once we start having those large scale studies, we can start to claim some of that stuff. It actually frustrates me because in Manitoba, I can't talk about diabetes. If I talk about diabetes on my website or on a patient testimonial, my board's going to come in and slap my hand and say, oh, you can't talk about that. There's no evidence. Us chiropractors only do neck pain, back pain, and headaches. And that is a massive, massive bone that I have to pick with our board and our profession in general. So we need to keep this stuff up. Okay, so here's a cool article that was published in the Journal of Physical Therapy Sciences. This patient had what's called flat back syndrome. If you're not taking lateral thoracics on your patients, please take them. I just showed you a case where the lateral thoracic was germane in helping a patient with type 1 diabetes. Here, I'm going to show you for the next like 5 studies. They're all about lung function, but it has to do with the thoracic kyphosis. So the patients that are coming in, they have straight back syndrome. Straight back syndrome, it's exactly how it sounds. Instead of having a nice thoracic kyphosis, when we look at them from the side, the thoracic spine straightens up quite drastically. Oftentimes, straight back syndrome will go even into the low back, so they lose the lumbar curve, and then the TL junction can become kyphotic at times. And so this is a case, right? Obviously, if they've got a straight thoracic spine, and we've mentioned this in previous webinars about, okay, how do you increase the thoracic kyphosis? Well, you have them lay face down on either a lumbar dental roll or a thoracic dental roll. And you can actually see for someone that's got like a flat back, look at, you're getting a nice increase here in thoracic kyphosis. Same thing. There's an example, right? Having them lay over top of a roll. And so this patient was a 33-year-old male, and they're saying he has exertional dyspnea. Fancy word for saying as this person starts to exercise or exerts themselves, they have a hard time breathing. Well, that's because flat back syndrome, it's literally the thoracic spine is so flat that the mechanics and the position of the thoracic cage has changed. And these people don't have the ability to have their lungs expand because the thoracic spine is almost like pushing into the lungs. They have reduced lung capacity. Furthermore, straight back syndrome is pretty serious because it starts to mimic heart failure. It starts to cause mitral valve prolapse and heart murmurs and issues like that. So it's really important to address these things and help our patients fix this by increasing that thoracic kyphosis. So in this case, the patient's thoracic kyphosis was improved or increased by 10 degrees, and that 10 degree was enough to resolve all of the issues of their exertional dyspnea, okay? Exact same type of case, exact same protocols, just different chiropractor published in the same journal. This time, the patient was seen again over 12 weeks. They had a 14-degree increase in kyphosis, so a little bit better increase in kyphosis. What makes this article a little bit better, they had a 2.75-year follow-up, which is awesome. And they're saying here that, obviously it's 12 weeks of intensive treatment, and the patient went on to more of like a minimal maintenance program. And at 2.75-year follow-up, the results are maintained. The kyphosis is still improved, and the person no longer has, what thought to be asthma. And I put asthma as one of the conditions that we were going to discuss, because often asthma can be misinterpreted for something like this, right? And in some of these case studies, it's exactly it. The patient thinks they have asthma until they find out they have a flat thoracic kyphosis. Boom, you improve the thoracic kyphosis, and the asthma is gone. Okay. And when we have long-term follow-up like this, it helps us because we can then state like, yeah, this is why we're doing care plans. This is why I see a patient over the long term. This is why I'm taking and making the effort to put a curve back in this patient's spine, because beyond a shadow of a doubt, the research shows us that that curve makes a huge difference at long-term follow-up. The great dental roll studies that we're going to talk about a little bit later on, they show, 2 groups of patients. One group that gets curve correction using a dental roll, one group that does not. At long-term follow-up, the group that does not get correction every single time regresses back to baseline. The curve correction is the key to the long-term outcomes and keeping our patients subluxation free, okay? A third case, exactly the same, flat back syndrome and lung problems. Here was, unfortunately, this is a picture right out of the article. It's a terrible picture, but I'm going to show it to you quick, and we'll see if we can explain how you would measure flat back syndrome. Not that you need to measure it, but it's understanding where are they getting this measurement from. Well, they take T4, right? So imagine that's T4, and they take T12. And what happens is as that thoracic spine flattens so much, you're losing the space between T8 and the line that ties T4 through T12. So it would be mid-height of T12, it would be mid-height of T4, and you would draw that purple line is supposed to represent the intersection of the height of T12 and T4, and then they go to T8, and they measure back from that line to see how much space there is in those lungs, right? And you're measuring from your line back to the front of T8 right there. In this case, this patient only had, where is it here, 0.84 centimeters. Well, anything less than 1.2 is a diagnosed flat back syndrome. So this patient starts out with only 0.84 centimeters, and then it's basically doubled at long-term follow-up here. You can see a much better thoracic kyphosis. You know, they did the same thing. We'll call it mid-height T12. Hallucinate with me, that's mid-height T4. And then when you measure from the front of T8 here, mid-height, you can see a much better or much bigger distance to that purple line, meaning the thoracic kyphosis is bigger, there's more space for the lungs to expand, and then that exertional dyspnea is resolved or reduced. Okay, so we talked about a flat thoracic spine affecting lung function. Here's a case series produced by Dr. Curtis Fedorchuk, where we're looking at increased thoracic kyphosis, so hyperkyphosis, also affecting lung function, okay? What was cool is that these patients all came in for different problems. So these are all asymptomatic in the thoracic spine. These patients did not have mid-back pain, but Dr. Curtis Fedorchuk takes, all these x-rays on patients. He measures everything on patients. He measures their spirometry. So he makes them blow into something to see, how hard can they blow and what's that max volume of airflow coming out. And what he notices as they corrected the thoracic hyperkyphosis on 3 of these patients, they had improvements in lung volume. So here you can see, like in their conclusion, he's saying basically there was an average of just over 10 degrees of thoracic kyphosis reduction. And in every single one of those patients, they saw improvements in peak expiratory flow and the forced expiratory volume. So again, there's a big body of data there that I just showed you that it is very important to have a normal thoracic kyphosis or as close to normal as possible for lung function. Okay. All right, Parkinson's symptoms. I was able to actually work with this patient. I was there when this guy came into the clinic in Eagle, Idaho. He was in his 50s, and the guy had pretty advanced and pretty serious Parkinson's symptoms. He would actually have to almost like run into the clinic because he couldn't walk, right? If he walked, he had such a bad shuffling gait, he would freeze, right? And you could see this posture. He was so stooped over. In a perfect world, that dot representing his ear is T1. The dot on the shoulder technically represents T1, and then this would represent the sacrum. Well, Parkinson's, if you've worked with Parkinson's patients, they have this classic stooped posture like this. And obviously, the further we start to shift forward, the more strain there is to the central nervous system. We know this, right? The further we distort from a normal position, the more we start to put stresses and strains on the central nervous system. And so this gentleman was shifted forward by 193 millimeters, or call it almost 20 centimeters forward. Parkinson's is a degenerative condition. So if you have a condition in the nervous system that is degenerative, and now all of a sudden you add this massive distortion, this massive subluxation, putting more strain to the nervous system, obviously this patient's Parkinson's symptoms are going to be worse, or they're just going to have a harder time functioning. Okay, so this guy did corrective care in the office. He did traction in the office all the time. He was doing exercises at home, and that's his posture post-corrective care. Okay, he had a massive improvement in the shuffling gait, in his freezing episodes. He had reduction in his pain. I mean, overall, fantastic results with this gentleman. He was not able to continue care for financial reasons. But Dr. Justin Anderson here, who was the lead author on the paper, followed up with him at 21 months, so almost 2 years after he had finished his corrective care. And the gentleman here told him that, yeah, he was largely able to maintain all of the improvements. He was starting to get some leg pain and some back pain again, but the Parkinson's symptoms, which they had reduced substantially, had maintained their improvements at almost 2-year follow-up. Super cool case, okay? Now we have a second case of Parkinson's, almost the exact same type of posture and positioning. This patient, though, really focused more on the cervical curve. They had rounding in the shoulders with the head going forward. And so on this one, there was a 15-degree improvement in cervical curve, and in which case the patient had a substantial reduction in Parkinson's symptoms. Urinary incontinence. Okay, here's a 75-year-old female that had obviously problems in the cervical spine and problems in the lumbar spine. When we're dealing with, pelvic organs, you're often going to see problems in the lumbar spine. This patient had a reduction in her lumbar spine. Obviously, she had a flattened lumbar spine. She had a flattened cervical curve. And so after care, she had improved cervical curve. But most importantly, she had a 12-degree improvement in lumbar curve, which is pretty substantial, and a complete resolution of her urinary incontinence. Now, I mentioned earlier, it's not just curves from the side, right? We're always looking at problems in the frontal plane too. So here's another urinary incontinence case, but in a much younger patient, okay? Much younger. She was 63, still younger than 76. So you don't want to be starting to run into these issues in your 40s, 50s, and 60s. It's very debilitating for people to have to deal with this. So this patient had a lumbar spine that shifted 40 millimeters out towards the left from her sacrum. She had a 40 millimeter left lumbar translation. And so what this chiropractor did was they did a traction where they decided, well, it shouldn't be that far over. Let's pull it as hard as we can to the right side. She obviously was lacking curve, so they also did cervical curve correction. So in the end, she had a 40 millimeter reduction in her lumbar translation, a 4-degree improvement in her cervical curve, and a complete resolution of her urinary incontinence. Hypothyroidism. Love this case. This is a cool case, right? And I like this case because it's one of those where here's pre-X-ray, here's post-X-ray, right? I mean, so many times I've had docs send me like X-rays and like, well, it doesn't look like it's changed much, or I don't understand why it hasn't changed much. Does that look like it's changed that drastically? It hasn't. If you measure it and you measure it properly, it's 7 degrees of curve change, and it's 4 millimeters of anterior head translation. That's pretty minimal, right? It's not a massive change, but it's amazing how even a small change like that can reduce pressure to the nervous system for the body to be able to improve and function. After 30 days of care, this patient came into the office and they were sweating, they were trembling, and the chiropractor realized, like, holy crap, you're starting to exhibit signs of hyperthyroidism. Right? Hypo, the thyroid's not functioning properly, not producing enough hormones. So we give the patient medication to, stimulate the thyroid, basically fake TSH, thyroid stimulating hormone. And what happens is you start to pump more thyroid hormones. And so the patient, after 30 days of care, had to go back to their MD and get a reduction of their thyroid medication because they were starting to exhibit signs of hyperthyroidism. So you can see that by improving the cervical curve, the patient's body was able to heal. As the patient's body was able to heal, they were able to regain function of a visceral organ. Very cool study. Same thing. I'd love to see a randomized clinical control trial on this, because it's very hard for us to use just one case study like this published in a chiropractic journal and say, we can change hypothyroid. If you say that with just one case study, you're going to get attacked by the scientific community, right? So it's great. I'm glad we have this. It's a starting point, but we need to take studies like this and make them into randomized clinical control trials, right? 30 people in each group, one gets correction, one doesn't, so that you can always confirm that the chiropractic curve correction was the factor that made the change, right? And I am confident that it is. And again, I'll show you on my last couple slides why I'm so confident that the curve correction is the key component. Tourette's syndrome. Great case. Here is one of those other cases that was at the Ideal Health Center. This patient flew in to get treatment because they did not live in the area, and they got 81 treatments over the course of 12 weeks, right? 81 chiropractic adjustments, traction, and exercise in 3 months. This was a patient that had a trauma at a young age, right? And they were diagnosed with Tourette's syndrome. After their 3 months of care, they had a 50% reduction in their medication for Tourette's, and they had a 50% reduction in the symptoms and the problems they were having. And what was really cool is that one of the chiropractors on this study followed up with the patient after 13 years, and the patient stated that, yes, they maintained, they were doing very well, and they continued to improve in time to the point where they were completely off of their medications for Tourette's. Very cool study because, again, that long-term follow-up is key for us. A second case of Tourette syndrome. I mentioned before, like, so here's a perfect example. If we're just looking at the lateral cervical curve, if someone is missing 10 degrees of curve, right? So they've got a 30-degree lordosis instead of a 40-degree lordosis. And I see this from the front. Which problem is going to trump here? Which one am I going to look at? You have to take into consideration what the spine looks like in the anterior posterior plane. This is a massive problem. This is a massive subluxation that needs to be addressed. So in this case, everything that was done to address, again, this problem that we see in the neck from the front, okay? Obviously, as that was corrected, and it wasn't fully corrected, it was improved, but as those angles improved, the CDA angle improved, and as the RZ angle improved, the patient's Tourette syndrome significantly improved. Okay, so now we're getting into one that's not necessarily a case study, right? We're getting into what's called a pilot study. Here is a pilot study that I think is going to be revolutionary for our profession. I think Dr. Katz is brilliant for having done this, and I know he's trying to get funding, and CBP is trying to get funding to try and create a large-scale randomized clinical control trial on this. I think I've covered this with the Warrior Group maybe a couple years back, so this is a few years ago now this was done. And what Dr. Evan Katz did is he rented out a facility with his own cash. Again, these chiropractors are so set on improving our legacy in our profession that they spend their own money to do this stuff, to build this data, okay? He took $50,000 of his own money and he rented out an MRI facility for the day. He brought 7 patients with him. And so what he did was he put them in the MRI machine, but it's really an MRA. MRA meaning angiogram. It's looking at the blood flow to the brain. So he would lay a patient in this thing, right? He would lay them down, he would put them in, and the scan would basically take a blood flow scan of the brain. And then what they would do is they'd pull the patient out. They weren't adjusting them. They weren't doing anything. All they did was just pop a cervical den roll under the neck and then push the patient back into the machine and rescan the brain, okay? And so what they found was that the blood perfusion, which is measured by pixel intensity, increased anywhere from 23 to 225% by improving the cervical lordosis, and nothing else. We're talking minutes apart. That is possibly revolutionary for our profession, right? If we can now start showing that not only does it have to do with the nervous system, we're affecting blood flow to the brain. Can you imagine what that can do for people with ADD and any type of cognitive disorder? Maybe that's one of the main reasons that when people start to distort and their head goes forward and they lose their curve, why do they have problems with concentration, right? Why do we become ADD? Could it be a fact that we just don't have enough blood flow to the brain to get proper nutrients to function properly? Maybe. And so a study like this, a large-scale RCT, like I said, could radically change how the world views chiropractic care and improving cervical lordosis. So that was a cool study, one of my favorite, only 7 people. So it's a pilot study. And now we need to show that, okay, can we curve correct the patient, and can this pixel intensity or this change in blood flow be held in the long term? So I know that's a study that's being designed and worked on. And some of these studies you have to understand from the day they are starting to be designed to the day it's published, it could be 10 years, right? It's very lengthy and they cost a lot of money. Like a randomized clinical control trial is hundreds of thousands of dollars to do. And that's why we don't have a ton of them, because a lot of universities don't have that kind of funding to be able to produce randomized clinical control trials. So we get a lot of case reports, right? You got chiropractors who are taking their time to write these case reports up for us. And we have a lot of case reports now in the literature of these different conditions that we can improve. But what we really need is higher evidence in the pyramid of things. It used to be, this should say non-randomized, this picture I took. I don't know why they both say randomized. You know, this is the hierarchy of evidence. I know Dr. Deed and colleagues, they're working on doing some meta-analyses, and they've produced a couple systematic reviews lately to try and, again, have information at the top of the pyramid. But we do have quite a bit of data here in CBP talking about curve correction for RCTs and non-randomized clinical control trials. And that is the data that we can really hang our hats on as chiropractors, because those are very good, high-quality studies, and we're getting more and more of them. So again, that CBP nonprofit page, you'll see that there are 277 articles that are produced and printed. And under the very first subheading under this, you'll see right here, it says the number of randomized clinical control trials and non-RCTs, up to 24, 17 of which are randomized clinical control trials. Now, what's so cool about those randomized clinical control trials, I want you guys to know, is they were researchers. At first, they were in Cairo, Egypt. And they started seeing some of this stuff, and they were like, "This is amazing." These researchers had a background in biomechanics of the spine, and they saw the work that the Harrisons were doing, and they said, "This is fascinating stuff. Why don't we start looking at when we change the curve in these large randomized clinical control trials? Can we start proving that the curve correction has impacts on things like neck pain and headaches?" And understand that it's neck pain and headaches because that's what a university is going to be interested in at first. And so those studies get published, right? And then it goes to back pain and sciatica and discogenic radiculopathy down the arm, randomized clinical control trials. Now it's a randomized clinical control trial. We looked at fibromyalgia, so getting a little bit away from neck pain and back pain. And then cervicogenic dizziness. Oh, that's pretty cool. Now we're getting, again, away from neck pain and back pain. And so it's building. And the more that the curve correction starts to show in the data that it's having an impact on these pain conditions, and now dipping into, that's why I put systemic disease or systemic function. Now the university might start giving more and more money to do bigger research projects on things like potentially diabetes or telomere length, right? And so the more that we publish case studies, the more that curve correction starts to show every single time that it's having an impact long-term on patients' health. There are more and more cool studies that are coming out. And these are two of the most recent ones that Dr. Deet has done. And this one was very, very cool because in this one, I believe every single patient was asymptomatic, trying to get away from pain. And what they did was they took 80 subjects, 40 in each group, control versus Denerol. The control group gets the adjustments, gets whatever else they're doing in that university. The experimental group gets that exact same stuff plus the Denerol. At 3 months, at 1 year, at 2 years, we measure the difference between the groups. Well, what was really cool is the group that got the Denerol had up to a 10% improvement in central conduction time in the cord. That is awesome. In other words, they prove that as we improve the curve, the brain can communicate with the body up to 10% faster. 10% is substantial, right? Some people might be like, whoa, that's not that much. 10% change in your reaction time for an athlete, for someone driving, for anything. 10% is a big change in an ability to measure brain-body communication. I thought that was cool. That is one of the most revolutionary studies that they've done. And then the other one, which we talked about last year, same thing. This is one that shows systemic disease or dysfunction, measuring the autonomic nervous system, a direct impact with curve correction and reducing sympathetic nervous system. If we can reduce the sympathetic nervous system, we know that long-term, we're going to have an impact on things like metabolic disorders and metabolic disease. Tons of them are associated with chronic fight or flight or hyperactivity of the sympathetic nervous system. So those are some of the cool studies. And I know that more and more research is being planned and it's going to get published, but understand that these things take time and they take money. So, I highly encourage you guys to donate to CBP nonprofit as chiropractors, monthly, $10, $15, you start getting thousands of chiropractors doing that. And it adds up to hundreds of thousands of dollars, right? And don't use knockoffs, use Denerol products. If you're talking about curve correction with your patients, if you're trying to put orthotics under a patient's neck and you're using this data and this information, understand that it costs money to do this stuff. And money comes from things like donating and CBP products, Denerol products. So it's super important to support those who support you so that we can hang our hats and have better data. And so, you're not working blindly like Dr. Ed and Dr. Yuri were talking about back in the day. It's like, this stuff. And yeah, we know it, but we need that data to prove it so that we can continue to push through and just get better results for our patients. So that's what I have for you. As always, in closing, there's a 10% coupon code for anybody that wants to use Denerol products. Again, to support this, here it is, WQ122. So you can just put that at the checkout when you're buying the Denerol products here on the Canadian site. And it's for 2 weeks. You can take 10% off any of the Denerol products that you want to buy from there. Here are my email addresses. Preferably, I know most docs are starting to use this one because you realize I really suck at answering this one. If you have case questions, please feel free to email me here and I'll help you out in any way I can. And then the YouTube videos for exercises, for Denerol placement and all that fun stuff, you can find it all there. So hopefully I didn't go too far over there and we can open it up for some questions.